Hello and welcome to PulseCheck with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling a disorder known as Stevens-Johnson syndrome, or more commonly abbreviated SJS. As always, let's kick it off with our practice question. A nurse is assessing a client who started trimethoprim sulfamethoxazole 3 days ago and now reports flu-like symptoms, a painful spreading rash, and sores in the mouth. Which action should the nurse take first? We have A, administer the prescribed acetaminophen and reassess the rash in 1 hour. B, document the findings as a mild drug allergy and continue the antibiotic. C, stop the antibiotic and notify the healthcare provider immediately. Or D, apply a prescribed topical corticosteroid cream to the rash. Think about it. Think about your priority there, and we will circle back to the correct answer at the end of the episode. But first, let's deep dive and really understand SJS, which means we need to zoom in on the skin first. I want you to picture the skin like a layered brick wall. The outer layer is the epidermis. It is made of tightly packed keratinocytes stacked in layers sitting on top of a basement membrane. Under that is the dermis, where we have blood vessels, nerves, connective tissue, and everything else that supports the skin. Mucous membranes in places like the mouth, eyes, genitals, and respiratory tract are similar layered tissues. They are just kept moist instead of dry. In a healthy person, this wall is a rock-solid barrier. It is going to keep fluids inside the body, pathogens outside the body. It's going to regulate our temperature and keep us safe. But when we have Stevens-Johnson syndrome, SJS, the immune system basically brings a wrecking ball into that brick wall. SJS is a severe delayed type 4 hypersensitivity reaction. It is usually triggered by a medication. A drug or one of its metabolites binds to the proteins in the skins, gets presented to the immune system, and then the cytotoxic T cells are like, all right, those keratinocytes, those are the enemy. I'm gonna go attack them. So that's not great for us, because once those T cells and the natural killer cells are activated, they really go into destruction mode. They release destructive molecules that trigger apoptosis. Remember, that's our programmed cell death of those keratinocytes. So instead of normal, calm skin turnover, nice solid brick wall, a massive amount of our skin cells die off. And when enough cells die, the epidermis, that top layer of the brick wall, starts to separate from the dermis underneath. That is what's going to show up clinically. Painful red spots that evolve into blisters, and then the sloughing off of the skin since that top layer is separating from the bottom. So the client ends up with these really large areas that are almost like a partial thickness burn, because we are literally losing the epidermis. Also, it does get worse because it's not just the outer skin. It's not just that outer epidermis. Those same immune attacks, the T cells, the natural killer cells, are hitting the mucous membranes. So again, these are like the brick wall. They're just moist instead of dry. And we are going to see that we get painful erosions, crusting and bleeding and blistering in those mucous membranes. The eyes can become red and gritty, really sensitive to light. And serious damage can occur on the surface of the eyes. The genitals and the urinary tract can develop ulcerations. Even the respiratory and GI mucosa internally can be affected. That can make breathing, swallowing, and eating very difficult and super painful. This is a really uncomfortable situation to have your mucous membranes and your skin literally separating. And in addition to how uncomfortable that is, we are going to see a cascade of complications that is really not good. When your skin barrier breaks down, first you have a massive fluid loss. So similar to what you would see in a burn patient, we have lost that ability to keep our fluid in the vascular space. It's going to be third spacing moving out, and that can lead to hypovolemia and shock. Second thing, the loss of the skin and mucosal barrier opens the door for infection and sepsis. Normally we keep all those yucky germs, bacteria, pathogens on the outside. Now they got a direct pathway right into our bloodstream. Boom, we can become septic real quick. Third thing, when mucous membranes are damaged, the things like eating, drinking, going to the bathroom, those become really painful. So all of a sudden, you've got a big nutrition and dehydration risk. You've got an airway risk with the mucosal membranes up here. This is just a massive issue. So kind of tying that together, order of events here, we give a medication. The immune system misidentifies the skin and mucosal cells as the problem, and it goes into attack mode. Cytotoxic T cells attack our keratinocytes, our skin cells. That causes them to go under apoptosis, where they destroy themselves, they die. We lose a bunch of our skin cells, and that causes the epidermis to separate from the dermis. The skin and the mucosa slough off, and we've kind of got a burn-like injury from the inside out. So that immediately opens us up to fluid loss, hypovolemia, infection, airway compromise, malnutrition, dehydration, and multi-organ failure as a result of all of this. So really quickly before we move into our case study, I do want to just briefly touch on a little terminology here, because so far I've just called this SJS, Stevens-Johnson's syndrome, but it is part of a spectrum of disorders. SJS is on the spectrum of disorders known as epidermal necrolysis. And, fancy word, but it really does tell us exactly what's happening. It's the epidermis, epidermal necrolysis. That tissue is destroying itself, lysing, dicing, dying. Epidermis is dying. Okay, so epidermal necrolysis is that spectrum. And then on that spectrum, we have SJS, what we've been talking about, but we also have something called toxic epidermal necrolysis, or TEN. And the only difference between them is just how much body surface area is involved. I'm talking about SJS right here because it's much more common, and it's when 10% of the body surface area or less is sloughing off. When we get higher than that, more than that 30% sloughing off of the epidermis, that is when we get into TEN, or that toxic epidermal necrolysis. So less than 10 SJS, more than 30 TEN. In between that 10 and 30 is kind of an overlap area where we're like, it's in between these two. But the underlying process is exactly the same. You don't even need another episode on this. We have got that drug that we've given. We have that immune reaction. We destroy our skin cells. Widespread keratinocyte death driven by that T cell mediated immune reaction. All right, hopefully that clears up the terminology, makes it nice and simple. Let's now walk through a case study. You have got a 28-year-old woman admitted to the step-down unit. 2 weeks ago, she was started on lamotrigine for a bipolar 1 disorder diagnosis. For the past few days, she's had what feels like the flu: fever, sore throat, cough, body aches, fatigue. She went to urgent care. She was told it's viral, go home, fluids and rest. But this morning she woke up and had painful red spots on her chest, back, and even the bed sheets she said hurt her skin. Her skin hurt so bad. When she tries to drink water, her mouth burns. So she went ahead and came to the emergency department, and she was admitted to the step-down unit. So you go on in the room. She looks miserable. She's febrile. She's tacky. Everything seems to hurt. She's holding her gown away from her skin because she's like, oh my gosh, anything touching my skin is bothering me. And as you assess, you see scattered erythematous macules on her chest, back, face. They have a darker, dusky center that kind of look like target lesions. By target lesion, I mean kind of like a target, like you're playing darts and you've got a bullseye, darker center. When you gently press on one area, the top layer of the skin kind of shifts over the dermis. That is something called a positive Nikolsky sign. Positive Nikolsky sign. That tells you the epidermis is detaching from underneath. So you basically just press, and, as I'm moving my skin here, the whole, dermis and fatty tissue is all moving together. But if you press on one area and that top layer shifts over the dermis, the skin is detaching. So further assessment, check out her mucous membranes. Remember, we usually have at least 2 mucosal sites involved. So we want to look at mouth, crusted, cracked lips. We might see shallow erosions on the buccal mucosa, so in the cheeks. Look at her reaction. When she tries to swallow, is she wincing? Look at those eyes. Remember, they can become red, watery, feel gritty, or sensitive to light. And because it's, hurting to try and drink, assess that hydration status. Really look at the skin tenting and, are the lips cracked and dry, and see about those signs of hydration. So for this client, it is really the classic progression of an epidermal necrolysis situation. We had the start of a new medication. There was, that flu-like prodrome for a couple weeks. And now a very painful evolving rash with mucosal involvement. So when you have that classic order of events, it is not a simple drug rash. It is an emergency. You need to recognize and escalate this really quickly. It's not appropriate to just document like, oh, rash present. You need to call the provider, communicate your concerns about Stevens-Johnson syndrome. You want to say something along the lines of, hey, she has a fever, painful rash with dusty target-like lesions. There's mucosal involvement and skin tenderness. All those things are playing into your critical thinking, your nurse reasoning as to why you have these concerns. Now, the other thing is you are holding farther doses of that med, okay? And you got to document that to make sure nobody else is like, oh my gosh, she missed a dose of this lamotrigine. I'm going to help her out and I'm going to go give that med. You want to make sure that we are withdrawing that offending drug. That is one of the most critical steps. That is what kind of set off this whole cascade. So hold that, call the doc, and then you kind of start thinking of this client like they have a burn, okay? They're sloughing off that tissue. So we need to think about fluid loss. We need to think about infection, wound care, hemodynamic monitoring, all of those things. This is a client that will likely be escalated to the ICU so they can have that closer level of monitoring. The provider is most likely going to get some labs. We want to look at renal function, electrolytes, inflammatory markers. Dermatology will probably be consulted. And they want to get photos to kind of track the progression. We want to see if this is getting worse, how quickly, or hopefully as time goes on and treatment is starts to get better. But most likely, at least for this client in our case study here, it is going to get worse before we see that point of getting better. Those lesions are going to blister and coalesce, and then that skin will start to peel away. You can almost think of it, this is unpleasant to think about, but like, a snake shedding its skin. That outer layer is peeling away, and it's going to leave behind a shiny, raw dermis that is oozing fluid and is very, very easy to bleed. That also makes it super hard to eat. Even, sipping water is going to be very painful. So not only do we need to think about conserving fluid and hydration, we're also probably going to need a feeding tube to maintain that nutrition, since the oral mucosa is too damaged for safe oral intake. There is a lot that you are going to do for nursing care for these clients, okay? In addition to, fluids, like we're a burn client, preventing infection. You've got a lot of wound care, non-adherent dressings, gentle handling, really protecting any area of newly epithelialized tissue. You work really close with the interdisciplinary team to manage her pain. Usually these clients are going to need IV opioids. And then we want to try to kind of cluster our care together so that we minimize unnecessary touching and movement that's just really, really painful. All the while you are tracking that fluid status like a hawk. You know, that open skin is just like an exit door for fluids that can lead to hypovolemia, that can lead into shock in the worst case. That hypovolemia can injure our kidneys. So we really, big nursing care things are fluids, monitoring I's and O's, keeping track of that urine output, those kidney labs, and we're going to be titrating those fluids to make sure that we stay at a good volume status. And as that skin grows back, then titrating them down so we avoid volume overload as she starts to heal. And last thing that I'll touch on briefly here is, even with all those really important nursing interventions, the fluid status, the infection prevention, the nutrition, there is a really big emotional aspect when we are dealing with either SJS or TEN, because the pain is so intense and they look very different, losing all that skin. There's scars. This is a long process. You're going to need to do a lot of therapeutic communication, explaining in a way the client and their family can understand, reassurance, and all of that really, really essential communication that our nursing care does. So all that being said, tying all that together, let's circle back to our practice question now. Let's see if you can get to the right answer and understand why. A nurse is assessing a client who was started on trimethoprim sulfamethoxazole 3 days ago and now reports flu-like symptoms, a painful rash, and sores in the mouth. What action should the nurse take first? We have A, administer the prescribed acetaminophen and reassess the rash in 1 hour. B, document the findings as a mild drug allergy and continue the antibiotic. C, stop the antibiotic and notify the healthcare provider immediately. Or D, apply a prescribed topical corticosteroid cream to the rash. Now, I know you guys have got it, so shout it out, jot it down. The correct answer is C. This is highly indicative of one of our epidermal necrolysis disorders. So we need to stop that offending agent immediately and get the healthcare provider to the bedside. It's a life-threatening drug reaction, so pull that offending med and urgently notify the provider. From there, you'll move on to interventions like fluids and infection prevention. A, administering acetaminophen and reassessing does nothing about the emergency. It delays critical intervention, so that is absolutely incorrect. B, documenting the findings as a mild drug allergy. Again, this is not mild, and we only choose document on our NCLEX questions if everything is normal. Everything is not normal here, so don't just document. And D, applying topical corticosteroid. That's the wrong treatment. It is totally inadequate for this systemic, life-threatening reaction, and it delays the essential step of stopping that causative med. That is your big takeaway. If you have tuned me out up until now, just make sure you remember. With SJS, if a client starts that new med and develops a painful spreading rash plus mucosal involvement, and they have systemic symptoms like fever or malaise, you need to think SJS. Your job is recognize that rash, stop that causative agent, and notify the provider. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to PulseCheck with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.